So, my name is Tak Ming. Um, so ethnically, I'm Chinese, but I'm Singaporean. So I have no affiliations with the Chinese Communist Party. Just to get that famous response from my Singaporean counterpart, who is the CEO of TikTok. So we're going to switch gears right now to talk about clinical pharmacy, and I'm actually very excited to be here in India because we use a lot of generics in Singapore just to keep our costs down from India, and we really truly appreciate the high quality of medications that we received. So today we are going to talk about antibiotic stewardship, and it's something that is close to uh, all of us, and it's actually very nice to see cancer treatment that was previously presented. So if you have for example, if you have a very high cost cancer treatment or transplant or a very complicated surgery done, the patient will have a bad outcome if there are no antibiotics to treat. So it's very important that we, as pharmacists, play our part in terms of driving the appropriate use of antimicrobials. So today I'm just going to share with you some of the things that we have done in Singapore as well as in my hospital. So I think this slide is just to show everybody that okay, there is a serious problem, and this is really 2015 data. And since then, we have a lot of carbapenem resistant organisms, and in Singapore we do see them. And in Singapore, about 50% of our gram-negative bacteria are resistant to first line antibiotics. So as you can see in our region of South and Southeast Asia, antimicrobial resistance is increasingly a problem. Next slide, please. Okay. So in Singapore, so Malaysia is our closest neighbor. So if you look at the Southeast Asia map, Singapore is but a dot. And because our flag is red, the Malaysians calls us the little red dot. So we are indeed a little red dot. Because when I was talking to some pharmacy students who are volunteers, I can't imagine their schools are 120 kilometers away. If I were to tell you the size of Singapore, east to west, 45 kilometers. That's it. Okay, and I can drive from one end to the island in about 45 minutes max. Yeah. So that's how Singapore is. So because we are very small and we are multi-ethnic, we have many, many people who come from all over the world. We have many people from India working in Singapore. And there's this great exchange of talent. But with the great exchange of talent, is also the great exchange of microbiome. So definitely you can see we are having a resistance problem. And 30%, 20% of our Klebsiella and E. coli respectively are already all ESBL producers, and those are in the community. We have increasing carbapenem resistance also, and that's usually seen in our hospital. And MRSA is endemic in our local healthcare facilities. We are trying very hard to remove the but it's just very hard. And once in a while, we will have outbreaks of vancomycin-resistant enterococci. Next slide, please. And so I just want to show this slide to show you that once you have taken antibiotics, right, you've exposed some microorganisms to antibiotics, the microorganisms will already, you will tend to suppress those that are sensitive ones and encourage the growth of the resistant ones. And it's just a few doses and you can see the effect. And we already know this very early. So this is the reason why, and this is the reason how antimicrobial resistance develops if you use antimicrobials. Next slide, please. But and this antimicrobial resistance is increasingly a global issue right now. And recently, I think the UN General Assembly, they have this 10, 20, 30 by 2030 targets is to reduce. They aim to have all countries in the United Nations to have a 10% reductions in AMR deaths, a 20% reduction in inappropriate antibiotic use, as well as a 30% reduction in inappropriate antibiotic use in animals. So antibiotic stewardship has increasingly becoming to go from the clinical care arena to now veterinary health. And later on, I will show you a review paper to show you that this has also been related to climate change. Okay, so And how do we rationalize antibiotic use? We can actually adopt the WHO very nice and simple way of reserve, watch, and assess, which they call it AWARE. So there's like a traffic light system, right? So for those that are the first lines and the common ones, you give people access because of the disparity in healthcare access. There is this need for us to maintain access so that everybody gets the antibiotics they needed. Because infectious disease control is actually the most important human advancement because it allows the people to do advanced surgery, immunosuppression, heart, chemotherapy, and so on in terms of the other medical sciences. Okay, so then the last but not least are the reserved. And these reserve are specifically targeted at the multi-drug resistant, for example, the KPC, the carbapenem resistant organisms, where you have the newer agents like ceftazidime avibactam, and also meropenem valbubactam. And it's something that I think is also to the advantage of the drug companies because with prudent use of their newer agents, these agents will tend to have a longer shelf life and longer time in the market. Next slide, please. So increasingly, there's this One Health approach, which I think is familiar to a lot of you. But I just want to show this slide because you can see that there's a natural environment subsystems that is now being put into the whole one AMR health system. So I think recent studies have shown that with every 1 degree rise in terms of the global temperatures, there is also correspondingly increased antimicrobial resistance, increase in terms of virus transmission, or even more, and also the transfer of zoonotic diseases to human health. Yeah. So these are some of the things that we need to keep in the back of our mind. And when we talk about climate change, which is something that's very hot right now, it also has implication in terms of antimicrobial resistance. And you see the red line on the other side. This is just to show you that there's quite a little thing, quite a very small little part that the humans can change in terms of trying to change the antimicrobial processes, because there are also other things such as the natural environment subsystems, as well as the rest of the things in climate and biosphere. Next slide, please. So back in 2017, in Singapore, we had this strategic action plan, and we have 4 different focus areas to make it a system-wide, country-wide strategy. So in humans, which is something that we are all very familiar with, trying to ensure appropriate antimicrobial use. Then in animals, right now, Singapore, we don't really have a lot of livestock, but we ensure the livestock that we import, for example, in Indonesia, Malaysia, or many other countries like Brazil, they do follow certain guidelines in terms of antimicrobial use. And also in food, which is related to the animals, as well as, and last but not least, environment. So increasingly, we are testing wastewater, making sure that the disposal of antibiotics are appropriate in our sewage systems. So most importantly, to build an antimicrobial stewardship program or antimicrobial or infection control, you need these 4 pillars of education, educating people to raise awareness. You also need to raise surveillance, and you need to have a surveillance and data capability, because without data, without surveillance, there's nothing much you can solve, because the problem is not being described and the effect of interventions is not being measured. And then last but not least, that's where the pharmacist's role comes, which I'm a clinical pharmacist, is really to work with our doctors, our prescribers, our advanced practice nurses, and our patients to make sure antibiotic use are optimized. Next slide, please. Okay, just go all the way because it's many. Yeah. Just press all. Yeah. Until you finish. Okay. So okay, I'll back up one. Okay. So this is so when I pitch antimicrobial stewardship to my hospital administrators, because clinical pharmacists who are practicing in hospitals, we don't make that much compared to pharmacists who are in the pharmaceutical realm, and we have to justify our worth so that the hospital budget is being balanced. So what we do is we have this value matrix. So the pharmacist will make sure that the correct selection, the correct dose, the correct duration, and the correct route of administration. So all these 4 rights, right, usually translate to quality antimicrobial use And it will then translate to improve patient outcomes, reduce adverse effects, and also improve our rate of antibiotic susceptibilities. All in all, we hope to be able to reduce the cost and also improve patient care. And this is divided by the resource utilization, because how much basically we spend in terms of taking care of a patient. So if the antimicrobial use is inappropriate, you can imagine that the length of stay will be increased. There will be much more complications down the road, and that's where you get higher optimized resource utilization, and you end up having lower value. So if you have a better improved patient outcomes, reduce adverse effects, you basically will have a better reduce cost on the top and improve value. Okay, next slide, please. Sorry, next slide, please. Thanks. Yeah, so as I mentioned previously, why we measure outcomes in our program is really to make sure that we have accountability to leadership. We are able to monitor and surveil our actions and describe our problems, and also evaluate the impact of our interventions. And last but not least is really to justify for program funding, so that we can do the work that we do. Next slide, please. So in terms of thinking about in your hospital, if you work in that environment or community hospital, how do you go about designing a program? What you can look out for is take this Donald Burnham model, which I learned from the UK people, of how they examine health services, and basically just look at structure, the processes, and the outcomes. And you should map out the whole different flow of how antibiotics is being used in your institution. It is not going to be prescriptive here, because in all different countries, jurisdictions, practice sites, the people who give approvals for antimicrobial budgets, the people who prescribe them, the people who dispense them, administer them, is all different. So these are just a guide for you as a reference. And most important, you have to look at the structure. So you have to determine the kind of structure that you're working in, so that you can be able to identify appropriate stakeholders and understand the environment that you're operating in. Next slide. So as you are thinking about implementing measures, it's also good to think about balance measure. And in terms of a lot of antibiotics stewardship literature, you will see that, they're going to use lower antibiotics. I want to reduce the use of antibiotics. So most commonly is when they reduce antibiotic A, actually the doctors don't change behavior. They will use antibiotic B, because you're telling them not to use A. I'm just going to prescribe for this patient. I'm going to use another one, and I'm going to escape you, right? So these are some of the things you have to think of the back of mind. And the other important balancing measure that you must measure is, if you are reducing antibiotic use, a lot of people will ask you, you are not actually thinking for the best of my patient, or not thinking for the best of my loved ones. So very importantly, you need to collect the clinical data to show that you are balancing the effect, such that the low antibiotic use doesn't translate to higher mortality in your patient group. Okay, next slide. So there are several interventions that you can do depending on your problem statements. And here I just want to list with you a few examples that is available in the literature, as well as what we have done over the 10 years in Singapore. So we do encourage people to investigate infection properly. So anytime if a doctor decides to start a systemic IV antibiotic, we request them to think very hard to do 2 sets of blood cultures, because your patient is having a systemic illness, therefore you want to give a systemic intravenous injection. If your patient is only have a localized infection, usually sometimes you don't have to do that. Orally you can solve the problem, or even topical antibiotics. The second thing is we also use antibiograms to design our guidelines, and those are very region-specific, hospital-specific, country-specific, unit-specific. And we do have also pharmacies supporting the different interventions, such as the very straightforward allergy checks, dose adjustment, IV to oral conversion. So anybody on like fluoroquinolones, triazoles, clindamycins, those antibiotic with more than 90% bioavailability from the orally, there's no reason to put an IV plug and then give antibiotics, because putting a plug site means the nurse have to look at it, the patient will have a breach in the skin, and then that could lead to complications like thrombophlebitis, etc. Okay, and then sorry, go back to the yeah. So we also encourage good prescription practice. We also implement surgical prophylaxis. So we do work with our surgeon a lot. And recently we have a national surgical prophylaxis guidelines we managed to persuade our surgeons to follow. Now we have win the war of selection of antibiotics. Now we are trying to win the war of don't give antibiotics beyond the first 24 hours. But these are only for very elective surgeries, the clean ones, not those that are complicated or there's trauma or there's some infection or perforation of the gut that you're after. So I'm not going to show you that tell you that we win already, but it's in the process of discussion. And then other things like Staph going disease specific, providing Staph aureus care bundles that has been proven to show to improve patient outcomes and reduce broad spectrum antibiotic use. And also guidelines for commonly acquired pneumonia, COPD, as well as urinary tract infections, which is my favorite ones, where you have a lot of elderly who have a bit delirious, and then a urinary test is done. Usually the urine culture will be positive because it's very common in especially in the elderly who are in the institutionalized, and then you have the pyuria. So the doctor will start treating, but most of the time there is actually no UTI, and this has been described a lot in the literature, but it's just very difficult to translate to practice. Next slide, please. Okay, so in terms of outcomes indicators, so just now we've gone through the structure and we have discussed about the process. Now we're just talking about the outcomes. The outcomes basically will be you need to measure the antimicrobial utilization, antimicrobial resistance, the clinical outcomes, and then last but not least, the financial outcomes, which is something that administrators love because they are trying to reduce the care budget, because the more profit from the hospital is if they can claim a certain treatment or a certain disease code from the insurers, that is just a standard price, right? Anything you can reduce, that extra component is profit. So we try to do that as much as possible to show that we limit drug costs in our hospital. Next slide. So in the public acute care hospital that I work in, we cover about 83% of all the hospital beds in Singapore. So there's about 20% that is private. These are really expensive. These are hospitals that cater to a lot of high net worth people from this country, from Indonesia, from Malaysia, and all over the world. So people like me who are Singaporeans, we tend to go to the public hospitals, which are as good. And then we have infectious disease trained pharmacists, which I happen to be one. I'm an infectious disease specialist pharmacist as accredited in my country. And then we have a guideline for training and practice. Then we structure our training program in all our hospitals that are following those guidelines. And last but not least, we form committees in our hospitals that are multidisciplinary, have a lot of different doctors, microbiologists, leaders involved, so that the committee has power. Because we are still Asia and healthcare is still very hierarchical, without the senior management support, without power, there is going to be much action. Okay, so what do pharmacists in Singapore do in terms of antimicrobial stewardship? So this basically is what we do. We have two roles when we are doing with prescriptions. We have a restricted antibiotic list. So for certain antibiotics, they need an infectious disease physician's consult before they can prescribe. So this comes under the pre-authorization and restriction part. So our technicians, actually not the pharmacist, technicians will check whether a certain order has the IE doctor's blessings. If no, they will call the primary team. We'll give them 1 day chance. Second day, we'll remind them. The third day, we will not supply the medicine. Yeah, so that's what we do, and the doctors have been quite cooperative with us. And the other part of the arm is where we hone in onto broad spectrum antibiotics, like those that we use for maybe carbapenem resistant infections, because those are precious. We want to make sure that they are used judiciously. We will provide prospective review and feedback. And then most of the time, I will persuade the doctor, this patient doesn't have a carbapenem resistant organism. Please don't use ceftazidime avibactam, for example. Go back to piperacillin tazobactam, or maybe something less less broad spectrum. I'm only successful 70% of the time. Being a pharmacist, the doctors can decide what they do. So the other 30% of the time, I have an ID specialist doctor that works with me. I will pass those to the ID doctor to talk to doctor. Yeah, then that is usually, and we can achieve about 80% success rate. So through that model, through this tier thing, we try to make sure our resources are divided and try to work together. Okay, now next slide, please. So here are some of our very early outcomes. You can show that, so this is one of the hospitals, Singapore General Hospital. We like to call them Singapore Greatest Hospital because I don't come from there. I come from the other hospital that's named after a Chinese immigrant called Mr. Tan Tock Seng. Okay, so this program started back in 2008, very early, and then in 2 years, they managed to show that acceptance of our interventions were associated with shorter length of stay. There was no difference in mortality, and there was a lower infection-related readmissions and 14-day readmission rate. But if you look at the antibiotic utilization, you can see that although cefepime and ciprofloxacin use reduced, there was increase in meropenem and also piperacillin tazobactam. So there is going to be a balloon effect if you ever do an antibiotic stewardship in a setting of high resistance and people are uncomfortable. But just cutting the duration, making sure the duration is 7 days or 5 days and not longer when they are not needed, you actually can reduce length of stay and improve patients' outcomes. And these are the part of the quality that we persuade our administrators and government about to fund us. Next slide. So we also managed to achieve other good clinical outcomes. And I just want to draw your attention is that so far we have been talking about changing drugs. But after a decade of antibiotic stewardship, working with my ID physician, I also learned how to order full blood count, C-reactive protein, procalcitonin. Sometimes I can suggest the doctor do some repeat imaging, chest X-ray, CT scans, and I do not order them, but I suggest to the primary team to do it. So this is our impact of non-antibiotic recommendation. And if they accept, it's associated with better mortality. Yeah, so this will show you that the impact of pharmacists goes beyond just the drug. You can really step up in terms of managing the disease by itself. Back one slide, sorry. Okay, good. Yeah. So this is just to give you an idea of what we do in terms of the non-antibiotic prescribing. So these are the exact words that I write in the clinical notes. Repeat blood cultures, order procalcitonin, repeat chest X-ray. Because with procalcitonin, I don't know whether you guys should have some procalcitonin tests in the hospitals here. Most of the time, people order one to see whether it's got infection or not. They start antibiotics and then they forget about it. So we persuade them to order on day 5 or day 3. If it drops below 0.25 or is coming down trend, you know when to stop. Yeah, so that's how we persuade them to do it. Okay, and then you can see the other CT scan suggestions that I was talking about. And sometimes I ask for help, consider infectious disease referral. So my favorite person is my infectious disease doctor because if I cannot handle, I'll pass it to him. Yeah, but I only give him 20% of the cases. Most of the things I do myself. Okay, next slide. Yeah. So in terms of, what I've been describing now is very manual, but manual is something that it's not something very valuable right now because we are all under the drive for productivity. So we have introduced clinical CDSS is computerized decision support systems, and there are many available in the market. So we designed one ourselves, and we measured the intervention. So when we first did it in the intervention 1, it's just PRF means prospective review feedback by pharmacists and ID physician team. The second one is when we put in the CDSS. So you can see that once we implement the computer system, which is basically something that pops up when a doctor orders an antibiotic and forces the doctor to go through a series of questions and answers before it allows them to prescribe. That led to a reduction in antibiotic use. And then intervention 3, what we did was we were trying to test whether our system is going to be helpful. We turned off the system for half of the hospitals. And you can see that after the system is turned off, antibiotic use did increase. Yeah, so this tells you that the reduction we achieved was due to actually the computer system providing point of care antibiotic decision support. Next slide, please. And here is to show you the impact in terms of antibiotic resistance. So you can see after intervention 2, there's reduction in ESBL, Klebsiella, and E. coli, reduction in Clostridial difficile infections, reduction in carbapenem resistant Pseudomonas, and also reduction in incidence of Acinetobacter baumannii. Yeah, and we also look at the balance measure, as I mentioned. There's no increase in mortality rates. Yeah. Next slide. So in terms of cost savings, in Singapore, we have shown that different hospitals have different cost savings because of different ways they measure it. If you just look at the cost of the drug alone, you're not going to get much because, as mentioned, we use a lot of generics. It's just a savings of about pre-AMS 175 SGD, and then post AMS, which is a prospective review and feedback, you save about $30 per patient. This is not a lot of money. But the acceptance of intervention from AMS reduced to about $8,416 per case. This is where we take into data such as length of stay and the rest of the other treatment costs, stay cost, and this becomes about substantial, about 8,000 Singapore dollars per case. And we've also further found that if the antibiotic use was inappropriate to start with, if you switch them back to the correct one, you actually can result in even much better length of stay, as well, much lower length of stay, as well as less overall cost. Yeah. So the more inappropriate the antibiotic is, or in this group of patients, the appropriateness is very low. If you go in and do your intervention, the more benefit is going to reap. Next slide, please. Yeah. So during COVID, we were quite lucky that we didn't have an explosion of antibiotic use that we see a lot in other hospitals that is reported in the literature, because we have this very, very strict antibiotic use policy, and our doctors are used to following guidelines. In fact, we actually have an antimicrobial shortage. So that makes people jittery, and every single antibiotic they prescribe, they are very careful because we import a lot of things. We don't manufacture them. Although the things that we manufacture are basically the finishing product rather than the APIs, and so this is the reason why our doctors are prudent. And you can see that there wasn't much effect when COVID came in terms of widespread use of antibiotics in our hospitals. Next slide. So in 10 years, we started measuring back in 2010, and then in 10 years, we have been able to show some in all the 7 acute Singapore General SG public hospital. We've been able to show reduction in antibiotic use in different classes. We also have been able to show some when that antibiotic use reduced, the resistant organism effects will reduce. So if you can get a group of hospitals together and network together to implement change, it really can lead to better outcomes for patients. Because imagine you have something that's sensitive, cheaper, probably safer, more experienced drug can be used compared to something that is newer. Next slide. Then there is this untapped potential, because in Singapore we have pharmacists like me who are AMS trained, but in my hospital there's only 7 of us out of about 200 pharmacists. So we hope to be able to empower the other 193 pharmacists to be able to do it. Yeah, so that's one thing that we are continuously trying to do, and empower them so that they can And in Singapore, every second prescription have antibiotic inside. So we really need to tap on this untapped potential, and these are some of the gaps that this is just some of the knowledge gaps that we have discovered in terms of pharmacists, and now we are trying to do some interventions to close them up. Yeah. Next slide. I'm coming to the end of my talk soon. So previously I showed you the computerized decision support system. Is basically a rules-based algorithm where it's like clicking things. So I think in future we want to go to the AI-based machine learning model where we can give predictive analytics on a patient's possible infection diagnosis, the type of resistant patterns that he or she will likely have based on prior data, and then also look at help the doctor to select the most effective therapy based on the treatment data we have in our database. So this is something that we are looking forward to in the near future. Okay, next slide. Yeah, so I think this is just some summary of what I talked about. So to be able to sustain antibiotic stewardship programs in areas with high resistance. You basically need to have continuous engagement with system level leadership, and it all goes up to our Ministry of Health, where we engage them and we do report indices from our hospitals to this committee. We have guidelines, policies that are similar yet specific to the hospital itself. Next step to do is to really empower our non-ASP trained pharmacists and then harness the power of AI. Next slide. So this is just my acknowledgement slides on my team, and the pictures are there. And if you are interested to discuss further, you can reach me at the email address. And then I have one last slide. Advertisement. End of the year, we're going to have a Singapore Pharmacy Congress. There's a 20% discount for delegates from India. So we hope you can visit Singapore and also join our conference. Thank you very much.
Thank you so much, sir, for your presence with the wonderful session.
Good afternoon, Mr. Tan. Your presentation is excellent. The thing is that you are actually focusing on the injection type of antibodies only. In the case of oral preparation, the problem that we are facing is actually the empirical dosage forms. Sometimes it is subtherapeutic, sometimes it is high therapeutic rather than the optimum therapeutic. This makes a lot of problems for the systems. How we are addressing that one?
Yeah, thank you for the question. So I just repeated back a question. You're asking because of sometimes antibiotic resistance and patient outcomes can be driven by subtherapeutic antibiotic levels. It's true. So there has been increasing literature that even for beta-lactams in the ICU setting, especially in patients who are critically ill, there's a lot of fluid shifts, physiological changes. There's a need to measure antibiotic levels, and those are not readily available yet. Mostly in the Western world, some in China, and we are beginning to do it. Yeah, so we can try to address that by therapeutic drug monitoring, expanding to beta-lactams. The other thing that we are trying to do, which is not me but my other colleagues, Andre Cross group from Singapore General Hospital, is looking at combination antibiotic testing. So when you put two antibiotics together, you may have synergism or additive effects. And they will look at therapeutic drug monitoring to design the specific dose that is slightly above the usual MIC breakpoints or MIC of that, but achievable physiologically. So increasingly there's this science of customizing patient doses, but it's very hard because your lab needs to be basically a lab that is accredited for clinical practice and yet can conjure assays from the multiple drugs that you use, and then the logistics of preparing assays, making them ready to receive samples is a whole cost nightmare out there. So I think the technicality is there, but it's just the implementation and the clinical outcomes is not so strong right now to make it widespread. Yeah.
Thank you. Your talk was excellent.
Thank you.
And way of narration was very attractive. Have you characterized New Delhi metalloprotease beta-lactamase there? There is a type of beta-lactamase resistance called as New Delhi metallobeta.
Yes.
Have you seen that in Singapore?
Yes, definitely. So I think in 2010, we welcomed our first NDM one, and it was a traveler who was being swabbed, and we found that the first colonization was reported in our fraternity. Since then, we have many alphabets, VIMS, IMS, and many others. Yeah, so it's a standard test that we do right now. We will make sure, because it's for surveillance and reporting purposes to ministry, we are actively monitoring it.
Yeah, I saw this interesting representation, Donna Padium, that diagram. So in that, if you draw similar diagram for Indian context, you will have to include many other parameters. One particular parameter is livestock, poultry. We use rampantly antibiotics. So that's contributing to AMR. That is not a problem there in Singapore.
It is a problem because we need to identify that the livestock that we import basically is really there's no live animals imported to Singapore. We basically process those animals outside and then import them already chilled or frozen. So our food agency just make sure that their antimicrobial contaminants are down to a certain level, and that's how we sort of deal with it. So we are not really dealing with it. We're just trying to protect our own people. Yeah, so I really acknowledge this is a huge problem that I cannot provide any advice on. And
Just
yeah, and I want to add another complication to that diagram I've drawn is to the availability of antibiotics in the community here and many Southeast Asian countries. So that's another complication by itself. Yeah.
last point is you talked on antibiogram. So can you just elaborate on that?
So antibiograms are basically you look at 1 year of worth of data in your hospital, all the microorganisms that's grown from clinical cultures. And then you choose the first culture from that patient, and then you group them into different types of bacteria, different antibiotic sensitivities that you already have tested. And that's what you, and then you have a percentage of sensitive to antibiotic A, B, and C, different degrees of sensitivities for a specific isolate. So that's your antibiogram. And then you think of if you are treating a pneumonia or UTI, what are the common organisms? You pick those organisms from the antibiogram and you design an empiric treatment to meet about 80 to 90% of the time it will work. So that is your empiric treatment. But for certain cases for us, because of high resistance, we end up having to have 2 or 3 antibiotics to increase our chance of hitting the organism empirically. Yeah. So that's how we use antibiograms. Okay.